Well, actually, I think the most interesting and hot thing in radiotherapy is now to bring together high technology with biology. So radiotherapy has profited over the last decades, I would say, but specifically over the last 15 years immensely from improved technology, being much more conformal, much more high precision radiotherapy. But what is the new frontier now is to bring new biology into that. Certainly for radiotherapy is a very important point. Biological imaging can provide more and more information about biology of the tumor. Let's say with PET imaging, for example, you can visualize areas in the tumor which are more radioresistant than other areas in the tumor. And that, of course, has implication on how you treat the tumor with radiotherapy. I think radiotherapy has applied individualized treatment already for a long time, because radiotherapy today is based on individual anatomic information of the tumor before the treatment. You do a CT and you use that for treatment planning, and many centers now also do imaging during treatment to see how is the tumor reacting, where is it really during treatment, and so on. So that's individualized treatment, and it's very translational also. But now we have to bring in the information, is this tumor in this individual patient a more resistant one or not? And there's good research ongoing in that direction, but it's not in the clinics now. I think that SNPs on normal tissues, because there's not so much diversity than in the tumors. SNPs on normal tissue reactions combined with imaging information on tumors probably is the first thing that goes into that direction. I think radiation oncologists have to look at a lot. Sometimes we are even facing arguments that we look too much in normal tissue reactions. I heard that some of us are obsessed by normal tissue reactions, but of course it's very important. We have the early reactions during treatment. We can handle that very good now in the clinical setting by supportive care, but we have the problem of late reactions, and so we have to really look into that, and we do. That goes very much in the direction of bioimaging, because with PET, for example, and in the future I think also with MRI, but now with PET, you can image hypoxia in patients and you can use that information. And there's no doubt that hypoxic tumors are more resistant than less hypoxic tumors. I think that's very well documented, and now we have to do interventional studies to really go into that direction. And one thing might be modifying hypoxia. That has been tried in several things and has been successful in some of the trials, has been not successful in some other trials. But for example, increasing dose is another option, of course. Well, I think that we get more and more aware of the fact that patients after radiotherapy can experience a second tumor. Yeah. And I just this morning in the hotel had a discussion with a radiobiologist who is in the moment bringing together epidemiology data on children and showing that it's really a problem there. And of course we have to cure the first tumor by the best modality we have. Sometimes we have options, sometimes we don't have options. If we have an option to either give this and this drug or do surgery only or give radiation and this drug, then we can learn somehow to prevent some of this tumor induction. But often we don't have the option. We have to use multimodal treatments to really get rid of the first tumor. So what we are talking about now is how do we need to produce surveillance programs of patients who are through their first treatment to really make sure that we could detect a second tumor and could also treat adequately a second tumor. As long as we do not have really the opportunity to say which treatment we tailor to which patient, I think we have to set up those structures. I agree, and it's not an easy topic, of course, and we have to learn a lot about that. what we can say today is that we can also cure second cancer patients. So a lot in the field of radiotherapy, for sure, a lot of really changing mentality has happened. We treat patients who had survived their first tumor. We treat in curative intent if possible, also when they really experience a second tumor, even if the second tumor is in the previously irradiated area. No, it's exciting, of course. That's a great time for multidisciplinary oncology in Europe. I think we have now really put our efforts together. A lot of things are emerging, very important things are emerging, and I'm looking really forward to that.